Transurethral laser enucleation of the prostate. Laser techniques for the treatment of BPH first evolved in the 1990s. Current treatments include photoselective vaporization, or PVP, and holmium laser enucleation, or HOLEP. This laser uses a wavelength of 532 nanometers, and the current high-power form is capable of efficient prostate vaporization. It is manufactured by AMS and marketed as the GreenLight laser. PVP has been proven to be safe, effective, and has durable results. In this video, we are going to show you a new technique for photoselective vaporization of the prostate, as well as long-term data on its safety and efficacy. The technique is easily learned by those with prior TUR experience. There is almost no blood loss and can be used on patients taking anticoagulation. No morcellator is required. Here's the equipment you will need for this procedure: a continuous flow cystoscope, saline irrigation, the GreenLight laser energy delivery machine, maximum power delivery 240 watts, the GreenLight laser fiber. The laser is emitted at a 70-degree angle from the tip, a 28 French cystoscope, rigid grasper, flexible grasper, and ELIC evacuator. We set the laser source to 80 watts and set the coagulation setting to 30 watts. This procedure can be done under either general or spinal anesthesia. Technique. This technique is essentially a hybrid between a TURP and a holmium laser enucleation. The cystoscope is inserted into the bladder under direct vision using a visual obturator. This procedure is efficacious in patients with large prostates, including those with large median lobes. First, we make an incision at the 6 o'clock position, bisecting the median lobe down to the level of the trigone. Once the midline channel has been created, we create an incision lateral to the median lobe and lateral to the ureteric orifices. These incisions allow for visualization of the ipsilateral orifice and lasering of the intravesical prostate away from the ureteric orifices. The intervening tissue is vaporized down to a narrow core, which is then separated from the prostatic bed and pushed into the bladder. The same is done on the other side of the median lobe. To complete resection of the lateral lobes, we then resect at the 11 and 1 o'clock positions. The intervening tissue is vaporized and removed as chips. We then vaporize any remaining apical tissue. This portion illustrates the TLEP from start to finish. In contrast to the traditional PVP, we do not make large sweeping motions. Instead, we use a steady proximal to distal motion without moving the scope. The blue marker is always in view. If it is not in view, then the laser is too close to the scope and may damage the lens. The laser fiber is kept a couple of millimeters away from the tissue to allow for optimal vaporization. Here we demonstrate our incision in the 6 o'clock position through the median lobe. We make this incision wide enough to create a channel that facilitates the continuous flow of saline to cool the fiber. Here, fibers are seen at the bladder neck. The ureteric orifices are distant from our incision. After the midline trench has been made, we make an incision lateral to the median lobe and lateral to the ureteric orifice. We carry this incision medial along the plane between the adenoma and the prostatic capsule. When large chips are made, these are divided into smaller chips prior to separation from the prostate bed. To avoid damage to the verumontanum, the chips are always carved from medial to lateral, beginning at the apex of the wedge-shaped intervening tissue. A small amount of scatter from the laser can injure the ejaculatory ducts and cause ejaculatory dysfunction. The same is done on the opposite side. Note the excellent visualization and almost bloodless field. Next, we reassess the prostatic urethra. If there is more lateral tissue, we again make incisions at the 11 o'clock and 1 o'clock positions down to the prostatic capsule. An incision is made medial to the adenoma and carried towards the lateral incision. The intervening tissue is vaporized and incised. The chip is pushed into the bladder. We then turn our attention to the apex. Apical tissue is vaporized if it is seen. This is a view from distal to the verumontanum after resection. Note the large channel to the bladder after all the adenoma has been removed. When we are satisfied with our resection, we irrigate with our ELIC evacuator to remove the prostate chips. Larger chips are removed with flexible or rigid graspers. Next, we check for hemostasis. Any bleeding is stopped using the 30-watt coagulation setting. The laser is extremely efficient at extinguishing bleeding. A 24 French 3-way Foley catheter is inserted. It is irrigated with normal saline. If the irrigation remains clear, signifying no bleeding, we leave the catheter to straight drainage. The catheter is removed in the recovery room. In select patients who have no bleeding, a catheter is not required. We now describe our 2-year experience with the TLEP. The procedure was performed on 276 patients with a mean age of 70. Mean AUA symptom score was 17.93. Mean preoperative PSA was 4.48. Mean prostate volume was 90.97. Mean time for lasering was 62.75 minutes, and the mean number of fibers used was 2.7. Over the course of 2 years, the mean decrease in AUA symptom score was by 64.25%, and the mean increase in maximum flow rate was by 74.46%. We had minimal complications after surgery, and not a single patient required a blood transfusion. Our results show that the new technique of the transurethral laser enucleation of the prostate, or TLEP, is safe, effective, and has durable outcomes.